Shantilal Sharma sir, Treasurer, NIMA Central. Further, it's my pleasure to welcome Dr. Kamini Dhiman ma'am, President, NIMA OBGY Central, Dr. Priyanka Nakade ma'am, Secretary, NIMA OBGY Central, Dr. Vishnu Bhavne sir, Treasurer, NIMA OBGY Central, Dr. Rajesh Bhavne sir, Convener, NIMA OBGY Central. And also like to welcome Dr. Sohan Sirlekar sir, President, NIMA OBGY University, Dr. Manish Gaikwad sir, Secretary, NIMA OBGY Maharashtra, Dr. Ajay Raj Bal sir, Treasurer, NIMA OBGY Maharashtra. So, before we go any further, let me just remind few instructions that are common for all the participants. Please keep yourself muted during session. If your mic is unmuted or disturbing or interfering with speaker's voice, you will be either kept in waiting room or removed from the session to maintain the decorum of program. If you have any question, please put your questions in chat box or raise your hand. Now, I would like to brief everyone about NIMA OBGY agenda. NIMA OBGY, that is National Integrated Medical Association, Obstetric and Gynecological Society of India, which aims to impart education in supporting and protecting the character, status, and interest of the integrated medical profession in general practitioner and practitioner of Strirok Prasuti Tantra, that is integrated obstetrics and gynecology in India. Our objective is to spread knowledge and foster education in integrated obstetrics and gynecology, including human reproduction, family welfare study, and research in the field of contraception and other allied problems. NIMA OBGY is committed to promote services for the betterment of health of community, especially maternal and child health, prevention of ailments and diseases, treatment with integrated approach of Indian medicine with modern sciences. So, with this, let's continue for what we are here today. So, dear, all of you know today's topic: update on the diagnosis and classification of FGR and stage-based management protocol. Fetal growth restriction, that is FGR, is the major public health concern and noted to affect approximately 10 to 15% pregnant women and result in significant perinatal mortality and morbidity. Approximately 30 million babies globally suffer from FGR every year. FGR is the second leading cause of perinatal mortality, which is still a huge problem in developing countries. So, today we are lucky to have with us the eminent speaker, Dr. Pradeep Musre sir. He will guide us with his novel thoughts regarding the topic. So, we welcome you, sir. We are honored to you with us. It's my pleasure to introduce all of you to Dr. Pradeep Musre sir. Sir completed his BMS and MS in Prasuti Tantra Strirok from Tirak Ayurved Mahavidyalaya, Pune. He is currently working as Associate Professor in Department of Prasuti Tantra Strirok in Tirak Ayurved Mahavidyalaya, Pune. He is also working as a consultant at Tarachan Hospital, Pune. Sir is the Director of Akshay Nursing Home, PCMC, Pune. He is also the Associate Partner in Pune IVF, Pimpri Saudagar, Pune. So, without wasting any time, with due respect, I would like to call upon Dr. Musre sir to start the today's session. Over to you, sir. Thank you.
Yes. Good evening, all of you. Am I audible? Hello.
Yes, sir. Yes,
am
sir.
I audible? Yes.
Yes, sir. Yes, sir.
Yes. Good evening, all of you. Guru Brahma, Guru Vishnu, Guru Devo Maheshwaraha, Guru Sakshat Parabrahma, Tasmai Sri Guruve Namaha. We all celebrated the Guru Purnima on last Monday. First of all, I would like to express my deep sense of gratitude to my great teacher, my guide and teacher, my Dr. Mahadevkar Madam, Dr. Tulpore Madam, and late Dr. Londe sir. Just because of them, I could do something in OBGY. I appreciate their guidance and support that given to me. And for proceeding next, I would like to thank Dr. Kulkarni sir, National President of NIMA, Kamini Dhiman Madam, President, NIMA-OBGYN Central, Dr. Priyanka Nakade, Madam Secretary, Dr. Vishnu Bhaune, Treasurer, NIMA-OBGYN, Dr. Rajesh Putane, sir, Convener, NIMA-OBGYN Central, and all the executive committee members for giving me this opportunity to express my thought uh, regarding the fetal growth restriction, diagnosis, classification, stage by management protocol, and last part is the last and most important part of Ayurveda, that is very important regarding the fetal growth restriction. Next slide. All of you know the Ford hypothesis. Ford means fetal origin of adult disease. It's very well known, the Barker, Dr. David Barker. The hypothesis that the associations between the small size at birth during infancy and later adult disease reflect the permanent effect on fetal undernutrition. That is, it is now widely accepted that the risk of the chronic disease such as insulin-dependent diabetes, hypertension, coronary heart disease may have their origin before birth. Professor David Barker and colleagues have produced large data in this issue. Dr. Barker showed that the lower birth weight and weight at 1 year of age are associated with the increased risk of death due to the coronary heart disease and stroke. Fetal adaptation. These words are very important. We'll get the explanation later on in last slides. Fetal adaptation, that is the cellular, metabolic, and physiological response to change in the environment in uterus and to prepare itself for the postnatal life, are become programmed and permanent. These words is very important, that this will get the epigenetic modification of gene expression. And that's why the Ford hypothesis is the eye-opener, because it suggests that the several common degenerative diseases could be prevented by the improving only maternal health and fetal development affected. That's why the Barker hypothesis is very important regarding the FGR, fetal growth restriction. Next, the magnitude. FGR globally affected 10% of people in Western world and up to 25% lower middle income countries. Fetal growth restriction is the second leading cause of the perinatal mortality next to the prematurity, counting the 30% of all stillbirth. Improved detection of IUGR, cause analysis, and timely intervention and coordinated care are the keys to prevent the adverse perinatal outcome. Next slide. Now, going to we should define the FGR and HGR. Previously, we used the term IUGR, but nowadays IUGR is outdated term. Intrauterine growth retarded, intrauterine growth restriction are outdated. Now the recent definition is the SGA term, is the SGA, and furthermore the FGR. That's why we have to differentiate between the FGR and SGA. Fetal growth restriction and small gestational age. The fetal growth is a dynamic process and its assessment requires multiple observation of fetal size over time. What is meant by fetal size? It's determined through the biometric evaluation of HC, head circumference, BPD, biparietal diameter, SC, abdominal circumference, FL, femoral length, and EFW, estimated fetal weight, computed by the different formula that we'll see later on. FGR defined as a failure to achieve his genetic growth potential regardless of the fetal size due to the pathological factor. What are the pathological factor? We'll see. The identification of HGR is often not straightforward, as the fetal growth cannot be assessed to the single biometric evaluation. No, not a single investigation is for FGR. We have to do lots of investigation and assess the fetal growth. The growth potential is hypothetical. FGR defined as a SGA with abnormal Doppler indices. Which are the Doppler indices? The uterine artery PI greater than 95th percentile, or mean uterine, umbilical artery PI greater than 90th percentile, and uterine artery PI greater than 95th percentile. Next slide, please. HGI is a heterogeneous group. The estimated fetal weight or AC less than 10th percentile is the a simple definition, less than 10th percentile. If you plot a graph, then 90 percentile, then 50th percentile and 10th percentile. If estimated fetal weight or abdominal circumference is less than 10th percentile, you should call as a SGM, small for gestational age. Is commonly used as a proxy for the being growth restricted. Smallness is defined as a effective estimated fetal weight or abdominal circumference less than 10%. And thereafter, severe HGA, that is mean estimated fetal weight or AC is below the 3rd percentile. HGA is not a synonym to FGR. The main difference between HGA and FGR is that the HGA fetus may be small but not increased risk for adverse peritoneal outcome, while the fetus with size above the 10% may be FGR and at increased risk of adverse parental and long-term outcome. Next slide, please. This is a graphical presentation. This is HGA versus FGR. Normal called as HGA, abnormal Doppler with estimated fetal weight less than 10th percentile or less than 3rd percentile is called FGR. Next slide, please. Classification is the very small for gestational age 3rd percentile, small for gestational 10th percentile. Appropriate for gestational age means 10 to 90th percentile. Large for gestational age above the 10th percentile, 90th percentile. Sorry. And the second classification is the HGA, severe HGA, FGR, SGA plus abnormal Doppler indices that I have told you, that uterine artery PI, umbilical artery PI, and CPR, cerebral placental ratio, that is less than 5th percentile for the gestational age above the 32 weeks. Next slide. For the confirmation of this, there is one international consensus is that is called the Delphi consensus criteria for the FGR. The Delphi consensus tells us involves both biometric and functional parameter of for the diagnosis of FGR. In Delphi consensus, congenital anomaly must be absent. The absolute size of measure used were defined cutoff, that is 3rd centile. And the functional parameter were added either alone, EAE, absent end diastolic flow in umbilical artery, or combination with umbilical artery with uterine artery PI greater than 95th percentile. It helps in proper diagnosis of FGR. That's why the Delphi consensus is there. Next slide. So we'll go what is the pathophysiology behind the FGR? That is the normal intrauterine. First, we'll see the normal intrauterine growth. There is 3 stages in normal growth of the fetus. First one is the hyperplasia. Second one is the hypertrophy. From 4 to 20 weeks, we'll see the cellular hyperplasia. It is very important for the growth of the fetus. Then after the 28 weeks to uh, uh, 28 to 40 weeks is the hypertrophy. That means the first stage is the cellular hyperplasia, and second one is the cellular hypertrophy. It's a if there is a pathological insult occurred. Sorry.
606 नंबरचं डिव्हाइस आहे, त्यांना म्यूट करा.
Pathological growth restriction of the infants causes of two types, the symmetrical and asymmetrical. Pathological insult occur in this process of the cellular hyperplasia or cellular hypertrophy. That means that you have to see the symmetrical and asymmetrical hyperplasia according to the hyperplasia and hypertrophy. Next slide. This is a graphical presentation. This is the cellular hyperplasia, symmetric FGR, and asymmetrical hyperplasia. Asymmetrical this one FGR due to the cellular hyperplasia. There is an intermediate FGR also, IUGR also, that is intermediate FGR. In this, we'll see the pathological insult in hyperplasia and hypertrophy also. Next slide, please. This is a difference between the symmetrical IUGR and asymmetrical IUGR. Usually, the early insult resulting decrease in cell number as well as in size usually present in late in gestation. That is a asymmetrical. Global growth restriction, it is throughout HC, head circumference is proportional to rest of the body in symmetrical. Asymmetrical is the AC lagging behind. The ponderal index is low. And if estimated EFW, that is below the 10%, may not be maintained normal growth velocity. There is a restriction of weight followed by this is one brain and limb ratio 5 to 6 times. Is more likely to have permanent neurological sequelae in symmetrical IUGR. Fetus adapts by brain sparing effect and diminished liver size, resulting in reduced abdominal circumference in asymmetrical IUGR. The cause is behind the placental insufficiency in most of the cases of the symmetrical IUGR, or aneuploidy, infections, and all these. In asymmetrical IUGR, the mild placental insufficiency is there. That is 70% of FGR cases are in asymmetrical IUGR. Features of malnutrition is less pronounced. Features of malnutrition more pronounced in asymmetrical IUGR. The prognosis of symmetrical IUGR is poor because there is a aneuploidy, maybe aneuploidy, infection, environmental toxin exposure. That means fetal pathology is the main cause. And the prognosis is good in asymmetrical IUGR. Next slide, please. All these are common etiologies of fetal growth restriction: maternal, placental factors also. Pre-placental factor means maternal, placental factor, umbilical cord, and fetal disorders. These are the all these hypoxia, anemia, smoking, substance abuse, cocaine. These are all the common etiological factors of maternal. And placental factor, the maternal vascular malperfusion of pathology, that is the infarcted placenta, fibrin deposition in the placenta, chronic abruption, secondary to hyperdensity disorder in pregnancy, fetal vascular malperfusion of pathology, that is chronic placental inflammation due to the viral infections. And umbilical cord, maybe increased coiling, increased cord length, true cord knot, single umbilical artery, maybe this one, marginal or velamentous insertion, cord insertion is the etiological factor for MCR. Fetal disorders may be genetical causes that we have to rule out, structural anomalies, and that we'll see that the teratonic exposures, drugs, toxin, these are the etiological factor for FGR. Next slide. Now we'll see the causes of smallness. What is the causes of smallness? The error in pregnancy dating, the first one. Pregnancy should be dated according to the CRL until 13.6 weeks or in second trimester from head circumference, 14 weeks from onwards. Second one, the HGA constitutionally small. This term is we use many times, the constitutionally small. It is a small baby fetus, but they are genetically programmed to be so. Small from second trimester, symmetrically small. Low or normal papping means and SCG. Maintain their growth velocity. And normal fetoplacental Doppler. It is called as the constitutionally small. Next slide. HGA, fetal diseases, anomaly and infection. Non-placental mediated smallness because of fetal diseases, aneuploidy and trisomy 18 is the commonest anomaly, commonest aneuploidy that is related to the HGA. Gastrocresis is the structural deformity, absence of abdominal muscle, and that the intestine is out of the abdomen. Small from the first, early or second trimester, symmetrically, asymmetrically small, both. High first trimester is aneuploidy, definitely. Low PAPA, pregnancy associated plasma protein A, and SCG. That is low because there is a chromosomal anomalies. Definitely, the PAPA may be low or SCG may be low. Reduce their growth velocity and normal fetoplacental Doppler. Maybe structural deformities because of structural and chromosomal abnormality. Next slide. The next one is the fetal infection. Now, fetal infections is due to the cytomegalovirus, rubella viruses, toxoplasmosis, plasma malaria infections, and trypanosomial positive patients. Small since infected, asymmetrically small, low risk and first trimester risk of aneuploidy. Normal PAPA and SCG, deceleration in the growth velocity. And there is a normal fetoplacental Doppler. Next slide. HGA, placental insufficiency now. Now you will see the there is a the placenta is the mediator for the fetal and maternal circulation that fundamental from the adequate exchange of nutrients and oxygen. It is considered that this adaptation results from the continuous physiological process called wave of trophoblast migration. It's a it's very important, the trophoblast migration. Trophoblastic tissue invades the muscular layer of the maternal arteries, that is the spiral arteries, end arteries, thereby converting them from high to low resistance vessel. The main problem is the incomplete invasion of the placental trophoblast. That is the main problem in placental appendage. Incomplete invasion. That's why the pulmonary means pre-eclampsia and then the HGA, the FGR babies develops. It starts from the second trimester, asymmetrically small. Low first trimester risk of aneuploidy, low PAPA. It indicates the low PAPA less than 0.4 is the indicator of placenta and future the placenta insufficiency, PIH, and FGR values. Progressive deceleration in growth velocity and abnormal fetoplacental Doppler is the sign of the HGA due to the placental insufficiency. Next slide. The causes of FGR now, the maternal. These will see the many of the these are comes in high risk and this last slide also you have seen that the small mothers means small weight means less than that pre-pregnancy weight is low, social determinant, malnutrition, anemia, smoking, alcohol, substance abuse, advanced maternal age, that is the main factor in today's era, IVF pregnancies, multifetal pregnancies, and uterine malformations, and medical disorder, that is the vascular diseases, diabetes, hypertension, chronic hypertension before the pregnancies, autoimmune diseases, just like that. Fetal, you know, the aneuploidy, now we will see anomalies, infection, torch infections, malaria, tuberculosis, and syphilis. We'll see. Next slide. It's a placental causes. That also we have seen all these things. Next slide. This is the risk factor now. It's also come in the same maternal deformity, medical conditions, obstetric history, biochemical markers, that is very important. Low PIGF, low PAPA, high AFP, alpha fetoproteins, and ultrasound-based markers, that is uterine artery pulsatility, the PI index, pulsatility index, that is 95th percentile, above the 90th. Uterine artery bilateral notching, marginal or velamentous insulin cord, two vessel cord, that is we have seen, abnormal placental morphology, decreased fetal growth velocity. Next slide, please. This is the maternal factor. Again, the maternal age greater than 40 and maternal greater than 35, that's nulliparity. Body mass index less than this 20, greater than 30. Maternal exposure to the cigarettes and all these cocaine and these things. Daily vigorous exercise, that is also come in the this risk factor. Low fruit intake and not taking diet properly, that is also income in these risk factors. Next slide, please. Medical history, that is maternal HGA. If previous baby is having the HGR, FGR, and the chances of getting the FGA or FGR baby in next pregnancy is double. If there is a chronic hypertension, any vascular disease, diabetes and vascular disease, renal impairment, Apla's positive antiphospholipid syndrome, it's a risk factor for HGA. Next slide, please. Previous HGA, previous stillbirth, if any stillbirth is there, and before that, there is a chance of 6% chance, 6 times greater chance of having HG or FGR in this pregnancy. Having preeclampsia, pregnancy interval less than 6 months, greater than 60 months. That is also the risk factor for HG also. Next slide, please. Factor HG related to current pregnancy. That is a PAPA less than 0.4 mom. That is a heavy bleeding in first trimester, creatinine abortion. Is one of the risk factors for getting the FGR baby also. First trimester bleeding. The echogenic bowel is the ultrasound finding. It is also a indicative risk factor for the HGR. pregnancy-induced hypertension, severe PIH, preeclampsia, that is one. Low birth weight, maternal weight gain is low low weight gain also is the one of the risk factor for the HGF. That is next slide, please. Now we'll see the there are the one to another causes is that the domestic violence during pregnancy, smoking, cocaine exposure, caffeine consumption. Many a times the patient takes too much coffees today. Today's in the IT people, they take the 3-4 cups of coffee daily. That is very hazardous to the baby also. The caffeine consumption greater than 300 milligram is a risk factor in for the FGR. Now we will come to the prediction of the FGR. All the pregnant women should be assessed for the risk factor for HGI neonate first ANC visit only. And with the first ANC visit, we have to confirm the LM, this gestational age, that is according to the means you have to confirm the LMPs on CRL basis. CRL of 15 to 6 mm corresponding to gestational period varying from the 8 to 12.5 weeks is found to have a greatest accuracy to determine the period of gestation in the first trimester. You can detect the if patient comes in second trimester, then we have to depend on BPD or head circumference only. Next slide. The best practice of segment FIGO. Once EDD is established in first trimester, it should never be reassigned on subsequent scans. That is very important. Nowadays नहीं बहुत से गायनेकोलॉजिस्ट ऐसे करता है कि बहुत बार ऐसा करता है कि हर टाइम कई सोनोग्राफी में भी ईडीडी चेंज होता दिखाई देता है हर सोनोग्राफी में, मगर ऐसा नहीं होना चाहिए. You should assign the EDD on first trimester scan only. What are the biochemical markers? The low PAPA, PIGF of first trimester serum analysis are the associated with the early abnormalities in the placental angiogenesis leading to FGR. Low level of PAPA less than 0.4 mom is the major risk for FGR fetus. Early second trimester increase the MSFP, alpha fetoprotein, and SCG are the most useful for their association with abnormal placentation and FGR. A single explained elevated value of greater than second mom increase the risk of FGR by 5-fold in absence of aneuploidy, neural tube defect, and abdominal wall defect. Next slide. Clinical suspicion of FGR. First and most is the poor maternal weight gain. Can be indirectly evidence of nutritional status of the woman, especially important in our country. Second one is the symphysis fundal height, SFH, in centimeter between 24 to 38 weeks of gestation, approximate weeks of gestation. That is very important. Next slide. Then how to measure the fundal height? The uterus should be stabilized first, and that should be measured from 24 weeks onward only. That correspond to weeks and centimeters. The uterus should be stabilized in the middle, this one, and one hand, and tape should be facing to the patient's abdomen, not the examiner's, in order to prevent the measurement bias. And that we have to measure the fundal height measurement. That is very important. Simple test, but very important, and to monitor, to assess the FGR babies. Next slide. FSH should be routinely measured from 24th week. That is from symphysis pubic fixed point to the fundus of the variable point, but should be centrally. And the lag of 3 centimeter in FSH used for identifying the growth restriction. It is simple and inexpensive, safe screening method to detect FGR. Next slide. FIGO 2021 prediction of FGR best practice statement. Strong recommendation is there. In high-risk population, uterine artery Doppler at 20-24 weeks have moderate predictive value for the severe HG. Patient with abnormal uterine artery Doppler should be serially monitored from 26-28 weeks for interval growth and umbilical artery Doppler. The woman should undergo risk stratification for FGR at the time of first trimester visit using history-based and medical wisdom. Next slide. Prevention, how to prevent this one? The women should be advised to avoid smoking, alcohol, tobacco, that means. Women should be advised associated individual gestational weight gain with FGR, consult for the nutrition and diet, nutritional supplement that should be done. Optimizing maternal medical condition, anti-malarial prophylaxis in women living in endemic areas may benefit. There is insufficient data to recommend routinely. This one routinely, this tablet aspirin, ecosprin that should not be given routinely. Next slide, please. Treatment of 100 to 150 aspirin starting may be considered in selected cases, such as women who have high risk of PI, PIH, preeclampsia, or those who have history of placenta mediated FGR. If PAP-A is less than 0.4, that in that cases only we should start the aspirin, ecosprin 150 milligram per day. And that low molecular LMWH is not recommended that for the FGR only. That is for patient only. Dietary changes and supplements should be given adequately and properly, but that not prevent the FGR. Next slide, please. Biometric test and biophysical test. These are the investigations in FGR. Now we'll see the investigation. What investigations should be done? What are the in diagnosing the FGR? Biometric test and biophysical. Biometric is ultrasound based, and biophysical, and that's mean that with ultrasound, but we have to see the Doppler indices and see all these things. And invasive karyotyping and screening. All these tests we have to in many cases we have to do that these tests also. Next slide. That is sonographic evaluation. It is very important. Ultrasound coronary system diagnosis. That is for surveillance and management of IUGR. Fetal biometry, estimation of BPD, SCAC, LCFL is used to estimate. According to that, BPD, SCAC, and FL, you can calculate the estimated fetal weight. That by Hadlock's method and all these for ultrasound in this. Fetal AC is the first parameters to be affected in FGR. AC, abdominal circumference, is the single best measurement for the FGR detection. Next slide. Screening from FGR by uterine artery Doppler is investigated for the prediction for early onset of FGR. First trimester uterine artery Doppler has high specificity and high negativity predictive value also. Sensitivity remains low for the small for gestational neonates. Screening can be integrated with 11 to 13 weeks aneuploidy screening. That is very important. Second trimester is uterine artery Doppler has sensitivity of 18 and specificity 95%. And for prediction of FGR also. Next slide. biometric ratio, head to abdomen ratio, femur to abdomen ratio. That will, if you calculated, that also gives the idea about the FGR babies. Next slide. You can plot the growth chart also. The single assessment of weight may not be accurate measurement for dynamic fetal weight. Plotting the fetal growth chart using population-based growth curves, that you will get all these growth charts in by sonologists and all this, that you have to plot regularly. That is very beneficial to uh, to get the FGR, find out the FGR babies, and according to that, you can treat the mother also. Loss or decrease in growth velocity may suggest truly growth restricted fetus. Growth curves are constitutionally small fetus will continue at normal velocity, but along the lower side. Next slide. These are the growth charts. You get all these things in sonology from sonography. Next slide. This is a customized growth chart. That means the variables adjusted for variable known to impact the fetal size, like a maternal height, weight, age, parity, ethnicity, that you can adjust along with that also. Next slide. It's a FIGO best practice statement. It's a again the FSH means simple, so fundal height measurement is the simple and inexpensive tool that can be used as a primary screening strategy for FGR. Growth standard charts are also useful. The local and regional growth charts should be preferred over the universal chart. That is very important. Next slide, please. The investigation now. It's a detailed anatomic survey, structural anomalies, soft markers that we have to see. The detailed anatomy scan also. Amniotic fluid that we have to see. Fetal echo to detect the major and cardiac anomalies, to evaluate the cardiac function also. And Doppler velocity. We can see that the fetal infections, the investigation can be done with ultrasound markers. That is, viral infection markers are small head circumference, ventriculomegaly, brain or liver calcifications, echogenic bowel, placentomegaly, hydrocephalus, congenital cataract. That these are the markers of the viral infections, and that maybe that comes in the torch, syphilis, again, and malaria, that we have to rule out by amniocentesis for the detection of the viral DNA in amniotic fluid using PCR technique. Next slide. Again, if you doubtful, that genetic evaluation also done by amniocentesis, karyotype chemistry, and that is, and again the whole exome sequencing and all these things that may differentiate the early FGR or severe HG also. Presence of soft marker, that is very important to see in sonographic finding. Evaluation placental cord membrane, that we have seen already, circumvallate placenta and all these things. Next slide. Now the Doppler velocity is the very important part of the this to detect the FGR. The uteroplacental function through the valuation of the uterine and umbilical artery, and fetal side Doppler velocity, that the middle cerebral, MCA, and ductus venosus, and that it's a part of the, we have to see the fetal cardiovascular adaptation progresses from hypoxia to acidemia. Next slide. The most commonly used nowadays in these indices of Doppler indices is the PI only, the pulsatility index. This is very well is used mostly while using to detect the flow velocity with Doppler. The uterine artery Doppler reflects the topoplastic invasion that is completed at the 23-24 weeks of gestation. On other hand, umbilical artery Doppler reflects the placental function and become abnormal if placenta is working less than 50% capacity. Uterine artery and umbilical Doppler assessment should be performed at the HGI diagnosis in order to detect the placental insufficiency and FGI. Progressively increasing PI in uterine artery 95% is associated with the placental insufficiency and maternal vascular deformity. Next slide. Uterine artery Doppler that reflects the tropoplastic inversion and placental development. Abnormal uterine artery Doppler shows reduced diastolic flow due to increased resistance to the blood flow in uterine vessel. Next slide. That you can see there is a normal uterine artery Doppler. You see that there is the diastolic flow is increased, and in below the abnormal uterine artery Doppler, there is a notch also that you see that there is a reduced diastolic flow. That is a uterine placental circulation, uteroplacental, uterine artery waveform. Next slide. Second one is the umbilical artery Doppler. It gives reflects the placental function and indicates the degree of placental insufficiency, progressively increasing PI in the umbilical UA correspond to the progressive reduction in the placental surface area available for the gas and nutrient exchange. That is very important in detecting the FGR patient. And the associated placental vascular insufficiency reflected by absent and end stage phase, the reverse end diastolic flow in absent diastolic flow and reverse end diastolic flow is very important in the umbilical artery Doppler. Next slide. This is the normal waveform, and this is the increase end diastolic, decrease end diastolic flow. You see there that there is a diastolic flow is decreased. Now here we'll see the diastolic flow is absent totally, end diastolic, AEDF, and reverse, that you will get the reverse diastolic flow, that is REDF. Next slide. The changes in umbilical blood flow with increasing vascular resistance. The elevated pulsatility index, this PI and resistance index, it is a very important changes. Early diastolic notch, absent and is a progressively deteriorating the umbilical artery Doppler. Last one is the reverse end diastolic. The high umbilical artery PI above 90% per gestational age with positive end diastolic flow EDF and AEDF and reverse AEDF reflects the placental insufficiency is 50%, 70%, 90% respectively. That means it's a progressively deteriorating. It's a elevated pulsatility index. It's a absent diastolic then, and last one is the reverse one. Next slide. Now we'll see the middle cell, MCA. The uterine and umbilical Doppler reflects the placental development function, whereas the MCA and DV Doppler, ductus venosus, Doppler indices reflect the fetal response to the placental dysfunction. It's a fetal origin. MC and DB Doppler. It's from fetal side. Cerebral vasodilation is the brain sparing effect. Well, many times we see the brain sparing effect on sonography. It's the cerebral vasodilation for the adaptation purpose. Reduce MCA PI and MCA MCA to UA double PI ratio, that is called as CPR, cerebroplacental ratio, less than 1 are early signs of fetal hypoxia. That is very important. Reduced fetal MCA PI is consequence of vasodilatation, so called the brain sparing effect. It is called as brain sparing. Reduce fetal MCA PI. Okay. Next slide. This is a middle cerebral artery flow. This is a normal, and this is a increase. This one. Next slide. Ductus venosus Doppler. Alteration in the ductus venosus flow velocity waveform is especially absent or reversed A wave are caused by progressive dilatation of ductus venosus isthmus in order to increase the blood flow towards the heart to the attempt to compensate hypoxemia. DV is the strongest single Doppler parameter to predict the short-term risk of fetal death in early onset of baby. It is used only early onset of FGR. It will see the early and late onset of FGR later on. Next slide, please. This is a waveform of ductus venosus Doppler. There is a diastolic flow and A wave is reversed. This is a waveform of the ductus venosus Doppler. Next slide. Now we come with the aortic isthmus Doppler. Many times we have to see this one also in doing the sonography in FGR babies. This one, the aortic isthmus Doppler is associated with increased fetal mortality and neurological morbidity in early onset of FGR. It is this Doppler done in early onset of FGR only. Reverse aortic isthmus Doppler flow is a sign of advanced deterioration. AOI has a strong association with both adverse or perinatal and neurological outcome. This precedes AOI, aortic isthmus Doppler precedes before DV abnormality by 1 week. Next slide, please. This is the aortic isthmus Doppler. Is descending aorta, ductus, ascending aorta, and there is a isthmus that is to take wave from this for the aortic isthmus Doppler. Next slide. Now, next parameter is the biophysical scoring. This is also to assess the FGR. It is combined scoring of fetal tone, body movements, fetal movement, breathing movement, amniotic fluid volume, and heart rate reactivity. And the BPP, biophysical profile score, can predict the both fetal pH and outcome. Relationship between the biophysical profile and fetal pH seems to be consistent across the gestational age. Useful surveillance of tool, definitely in FGR, has good negative predictive value in high risk patients. There is a BPP test score is also 8/10 is reassuring, 6 to 7/10 is equivocal, 4/10 is the positive test. First one get affected is NST during deteriorating the fetus. Now, first one get the NST get deteriorated first, then breathing, then fetal movement, and lastly the tone. That we'll see the in NST parameters. Ultrasound FI is also very important. one thing is there is the modified biophysical profile also done in these cases that contains the NST, non-stress test, and AFI, amniotic fluid index. If the result of modified biophysical profile is abnormal, then full biophysical profile is performed. That is very important. Next slide, please. These the 4 components of BPP, and we'll see the non-stress test also. Next slide, please. Now come with the CTG. We'll see all these parameters in normal NST, typical, and abnormal cell. There's a in NST means cardiotopography. We'll routinely do in labor patient and ANC patient also for surveillance purpose, for monitoring purpose also. Next slide, please. So it is a simple, low source, non-invasive test for fetal well-being. CTG is electronic method for capturing the recording the FHR and uterine activity to evaluate the fetal well-being during pregnancy and labor also, to identify the fetus with hypoxia. High false positive rates definitely because of this inter and variability, inter-observer variability is more in CTG and NST. That's why lead to unnecessary interventions occurs. Next slide. How to read CTG? That use synonyms: Dr. C. Braudo. DR definitive is define the race, C is the contraction, price, the baseline rates, variability, acceleration, deceleration, and overall impression. This is a baseline FHR. We have to see, interpret during the that NST that baseline FHR, acceleration, deceleration, early deceleration, variable deceleration, late deceleration, prolonged deceleration, and baseline variability. It comes with sinusoidal pattern and saltatory pattern. It's very important. Saltatory pattern means that there is a baseline variability is greater than the 25 beats per minute. It is the next slide, please. NST is a all these will do routinely for surveillance purpose. Next slide. Is surveillance tool to detect hypoxia or acidosis, which can lead to the fetal brain injury in normal or already compromised fetus. The low oxygen condition persisting, the hypoxia first occurs, then hypoxia, acidosis, and after that asphyxia is occur in baby and fetus. Fetal response is to persisting the low level of oxygen. Fetal response to persisting low level of oxygen, that is hypoxemia. If it persists the hypoxia, then acidosis occurs, and then birth asphyxia occurs. Many times we come across this one computerized CTG message, but it is not used in India. No, it is not. It's a very reliable assessment of CTG, definitely. But it is the availability of CTG is extremely limited. It's not still it is not used in India, but it is commonly used in foreign countries. Next slide. Fetal movements count. It's a simple and very best method, inexpensive and very simple tool for the fetal monitoring in FGR pregnancies in home setting also. Reduce fetal movement, FM, is defined as a less than 10 movements in 2 hours during focused maternal counting on rates in left lateral position. It is well-known fact that the fetal hypoxia sets in the fetal activity is reduced. So decreased fetal movement can trigger a hospital visit. Further investigation, USG and NST should be done. while normal activity can be helped to reassure the mother also. The amniotic fluid, that also is very important to detect the important component of evaluation of fetal well-being. It is the only the indicator of placental perfusion and fetal urine output also. More than 2 centimeter of SUV, single vertebral this pocket, the normal one, and single this one less than 2 centimeter is a oligo, and normal is a single vertical pocket. That is normal is a greater than 2, less than 8, and polyhedron is greater than 8. And AFI is calculated as a from 8 to 25. If they're less than 8 is oligo, greater than 25 is a polyhedron. Next slide. Amniotic fluid volume reflects the fetal urine production, definitely. And placental dysfunction may result in diminished fetal renal perfusion, leading to oligohydramnios. That is also very important. And AFI evaluate long-term uteroplacental function. Is AFI evaluate the long-term uteroplacental function. Okay. There is one method also is the placental grading also is there, but it is now not using in ultrasound. But there is a term is the placental grading for second, third grade. Now many times according to gestational age, we can divide this FGR in 2 categories: the early FGR and late FGR. The cutoff is optimal cutoff is 32 weeks. The before 32 weeks is early FGR. It's and after 32 weeks is the late FGR. FGR defines existent placental insufficiency, definitely. And these two are different phenotypes, early FGR and late FGR. Next slide. What is meant by early FGR? 20 to 30% of FGR. It is associated with early preeclampsia to 50%. Highly associated with severe placental insufficiency, early FGR, EFGR. Maternal vascular malperfusion of placenta, that is a placental insufficiency is the cause for the EFGR. Placental mediated FGR. Many times this umbilical artery Doppler is abnormal. Okay. Next slide. Next slide, please. This is a LFGR. Second one, 70 to 80%. Associated with the late preeclampsia is low, 10% only. Placental disease is mild. That means the umbilical artery PI is normal. Abnormal CPR value. See, the CPR value is very important in FGR. Advanced brain vasodilation, such as in chronic hypoxia. MCA get reduced the 5th percentile. MCA means cerebral artery. High contribution to the late pregnancy mortality. High association with intrapartum fetal distress and neonatal acidosis. Undergo rapid deterioration leading to severe injury, death without late stage of signs. Many times we see these babies, such type of LFGR, the patient already absolutely normal in third trimester, 35, 36, and comes with reduced fetal movement. We'll see the FGR is not audible. The sudden fetal death is a main cause, because of LFGR. Low tolerance of fetus, that is because of low tolerance to term fetus to hypoxia. Next slide. This is a graphical presentation of FGR. They're very small. there is a resistance, increased resistance, hypoxia, and acidosis. The ductus here in EFGR early, the ductus venosus is very important and to take the decision for delivery. And this is the normal way. And LFGR. In LFGR, the MCA Doppler is very important and CPR value. Next slide, please. The Delphi consensus criteria to differentiate the early and late FGR. There's before 32 weeks, after 32 weeks. The next slide, please. So difference between early onset and late onset of FGR management 32 weeks, and you can take the this photograph of this one. This is very important to differentiate between the early onset and late FGR because the management is very different, and the monitoring is very important in early FGR. Because perinatal mortality is high in early FGR, EFGR, and perinatal mortality is low in late FGR. Next slide, please. Common issue of EFGR and LGR. The main chronic exposure to adverse intrauterine environment is critical to determine adverse fetal programming. That is very important. Adverse fetal programming is there in both EFGR and LGR. Different adaptive programming responses. It is also common in EFGR and LGR. And both are caused from placental diseases only. EFGR associated histological signs of abnormal early implantation. This might be developed late placenta in LFGR. Next slide. Next slide. The diagrammatic ayuja, fetal hypoxia, brain sparing effect, then decrease the blood flow to the peripheral and placental circulation. The decrease in diastolic velocity in UA, umbilical vessel, and it increase end diastolic velocity MCA because of fetal hypoxia. Next slide, please. Again, the deteriorating stages. This one, elevated resistance umbilical, brain sparing effect comes in middle cerebral, absent diastolic, reversal flow, absent reversal, and fetal death after that. Next slide. Medical management in FGR. Till now, no drug alternative therapy has been found beneficial in FGR according to the FIGO 2021. Treatment that does not work. We see the bed rest, it does not work. And practically, we see all these things because the maternal oxygen supplement and low dose aspirin, beta calcium channel blockers, and L-arginine. That is, I think it is all the not work in medical management in FGR. Next slide. Since no treatment has been demonstrated to be benefit in growth restriction, assessment of fetal well-being and timely delivery remain as the main management of strategy. That is very important. The aim of managing the FGR is to combine the various methods of monitoring fetal well-being in order to establish the risk of fetal injury or death and to balance them against the risk of prematurity. We have to balance the condition of the fetus and again the prematurity also. If you deliver the prematurely, heterogenic premature. Next slide. The aims is next slide. The gestational age, severity, and maternal factor. We have to timing of delivery manage according to gestational age, severity of FGR, finding the fetal monitoring test, whether it is positive or negatives, and maternal factors also depend. That is a preeclampsia, severe hypertension, abruption placenta. That's a maternal health syndrome that it contains in the maternal factors. This HGA, we can deliver the 37, 39 weeks mode of delivery induction. There is a normal Doppler, normal fluid. Uncomplicated FGR, less than 30 percentile only, delivered at 37, 38 weeks. Next slide. FGR, mild abnormalities, early Doppler changes, we can deliver 34, 37 weeks. Mode of delivery, give induction, observe the patient. If there is a fetal disease, another thing, we can go for cesarean section. FGR with umbilical Doppler, artery, AEDF and REDF. That is reverse end diastolic flow. Then absent end diastolic flow, we have to deliver 32 in between 30 to 34 weeks. REDF 30, 32 weeks. Mode of delivery, cesarean section, definitely. No induction, no vaginal delivery. FGR with abnormal ductus venosus, definitely urgent sonography. Urgent means urgent go for delivery by cesarean section only. Next. Stage based, there is these are stages: stage 1, stage 2, stage 3 classification: fetal growth restriction, fetal growth, severe smallness, and severe placental insufficiency, advanced fetal deterioration, and high suspicion of fetal deterioration. Next. According to that, we can plan the deliveries. Severe smallness criteria. If these are the criteria, you can take this photograph of this slide. It's very important to manage the FGR babies. How to manage, how to monitor it, and how frequently we have to manage, monitor it. That I have given in this slide. Next slide, please. Deliver at any gestational age. Spontaneous repeated persistent spontaneous repeated and heart rate deceleration is very important for deliver at any gestation. Altered BPP score less than 4, delivered definitely any age gestational. Maternal indication: severe PIH, health syndrome, obstetric emergency, abruption placenta, and all these. Absent reverse UAEFD, umbilical end diastolic flow. And fifth one is the reverse ductus venosus. Next slide. Next slide. Best. These are the best practice statement for the management of FGR that I have already described before this slide only. Next slide. MCA is seen to be guide monitoring, but there is no evidence that it should be used for determining delivery timing. It is very important. Next slide. Use of umbilical Doppler in FGR improves the perinatal outcome in above the 80% of FGR fetus. Abnormal UA forms have been reported to be present 2 weeks before the acute deterioration. UA Doppler, umbilical Doppler studies is used for surveillance and obstetric management of early FGR. Absolute indication of delay that we have seen already. Next slide. Best these again the FIGO 2021 best practices statement management for LFGR. It is a several studies found this association between MCA dilatation, altered MCA PI, and UAPI, and poor parental outcome, including stillbirth. Cesarean compromise and neurofunction delay. Next slide. Next slide. Cerebral placental ratio is more sensitive to hypoxia than its individual component. That means MC or UA. With individual component correlates better with adverse outcome. CPR should be used as an additional tool to fetus undergoing ultrasound assessment, regardless of result of UA or MCA measurement. Okay, next slide. Consequences, that means, but before that, you have to see the, before going to the delivery, before you have to give the corticosteroid prophylaxis and Maxal also. The corticosteroid, then the steroid should be given before any delivery. That means before 35, 36 weeks, you should give the steroids to the mother for neonatal RDS and not to develop in complications of RDS in babies after delivery. So that should be given intramuscularly. We should give the dexamethasone or betamethasone, can both, but dexamethasone is more of use. Give the dexamethasone, the 6 milligram 12 hourly for 2 days. And for neuroprotection, you should give the Maxal, magnesium sulfate, that is 4 milligram, 4 gram stat, and after that 1 gram per hourly till the delivery. Next slide. There's a fetal neonatal problems associated with the FGR, fetal hypoxia, acidosis, stillbirth, oligohydramnios. All these are associated FGR only. Next slide. Intrapartum complication, neonatal complications, RDS, MASA, meconium aspiration syndrome, persistent fetal circulatory PIH, pulmonary hypertension after delivery, intraventricular hemorrhage, newborn encephalopathy, hypoglycemia, hypocalcemia, hyperviscosity of blood that may occur due to the FGR. And long-term outcome is the lower neurodevelopmental score. Next slide, please. Till now, we have seen the all the management and pathophysiology according to the modern science. But there is a men's concern is the management and treatment. According to modern science, there is no definitive treatment for FGR or SGA. We can manage, definitely we can monitor, do surveillance in FGA patient very nicely by all the gadgets that we have seen, the sonography and all these investigations, NSTs and all these things, biophysical profile. But according to the modern science, there is no definitive treatment for the FGR or SGR. So we are lucky that you can treat these cases with Ayurveda, definitely. And definitely there will be the good outcome prenatal and postnatally also. Next slide. The Ayurvedic concept of FGR. The many these are comes the FGR. There is no phrase or terminology in such terminology in Ayurveda. but Garbha Vyapad, you can see all these things in Garbha Vyapada. In Ayurveda, there are seen the 8 diseases which are related to the FGR. First one is the Garbhashos. Due to the non-availability of proper diet, nourishment to the fetus or vaginal discharge and bleeding after conception, the fetus suffers from shosh, emaciation or dryness. This fetus attains its proper growth or maturity after years, and woman delivers after years of prolonged delay. The vayu is said to be the cause of dryness of fetus. This is called as garbhashos. Second one, upavishtak garbha. That is also after some development of attainment of SAR after 4th month by the fetus if bleeding per vagina or by the fetus. If bleeding per vaginum or other types of vaginal discharge occur due to the use of pungent and hot articles by the pregnant woman, then the fetus does not grow properly due to this discharge and stays in uterus very long time. The condition of upavishtak. Next slide, please. The third stage is against the Nagodar Upashushka Garbha or Lina Garbha, Garbhakshaya, Garbhavruddhi, Vatodara, and Bhuta Garbha. These are 8 are comes in related to the IUGR phenomenon. The next slide, please. We'll see the how will you correlate these 8 this one to modern science. The Garbhakshaya underweight fetus with intrauterine growth retardation, Upavishtaka, Nagodar, and these are according to the modern science. You can correlate these Vyadi to correlate this one. But this one, these Pavishtaka, we can call it as a FGR. Another one, this one, these are all these avasthas are come later on if you have not treated the Upavishtak Garbha properly. Then the Nagodara, Upashita, Lina Garbha, this comes in later on. Next slide. Management. This is very important. Management of Upavishtak Garbha by Ayurveda. Use of Jivaniya, Bruhaniya, Madhur, Snigdha, and Vatahara Dravya with gruth, milk, and meat soup. Milk treated with Madhueshti, fruit of Kashmiri, with Sariva and mixed with sugar should be prescribed. Milk should be prescribed as it provides nourishment and stabilizes the fetus. Milk medicated with Sita, Kashmiri, and Madhuka should be prescribed. Mediated Grita, Vacha Grita, or Maha Pashachika Grita, that can be used as a for the management of FGR according to Ayurveda. Arundatta opines that and this is when if you go in Ayurveda classics now, Arundatta opines that she should be made cheerful repeatedly during pregnancy. It is very important during ANC period. Next slide, please. She should take take milk treated with decoction of juice of Madhuka and Vidari. Rice gruel cooked with the gruta extracted from goat's milk and this one. And drugs with Jivaniya group should be prescribed. The woman should be repeatedly be made happy. This is also important according to Ayurveda. Eshtimadu and Gokshur Siddha Kshirabasti, Shirapaka. We all these use and many times we'll get the good result from this one. Madhu and Gokshur, Siddha, Shirabasti and Shirapa. Routinely, many times we give this in our practice that Shirabasti of Madhu and Gokshur 100 ml for 8 days in ANC period and FGR patient, and Shirapaka for a 50 ml daily till delivery. It gives very nice result. Brunia Gana, Siddha, Kshirabasti or Kshirapa. I use in my practice that Lagu Malini Vasan, Swarna Malini Vasan, and Madhu Malini Vasan in period of 3 trimesters. First trimesters, Lagunu Malini Vasan I routinely give, and second trimester, Swarna Malini Vasan, and third trimester, Madhu Malini Vasan. It gives excellent result in FGR patients. Month-wise regime, medicines in pregnancy, dietary means Saptadhatu regime. That is also we use. We use the Shingada. This is a Prajastapak, Balya, Guru, Ruksha, Madhura, Kashaya, Shitavirya. Garbhastapak hai. Or Kushmanda, second one. Bhuikola. That is one the Buddhivardak, Ras Madhura, Vipak Madhur, and Viryashid. That is a Bruhan, Maunsameda Bruhan. We get the excellent reason, this one also, Kushmand and Shrungatak. We can use Dudhi Pofla, Dhatu Vishti Vardhanam, Garbha Poshak Kruta, Sapta Dhatu Vardak, ye Dudhi Pofla. We have come across this one, Jivaniya, Madhuriya, and this gun जो है उसमें से हमने शतावरी, अश्वगंधा, धमासा, ओक्षुर, विदारी, श्वेत मुसड़ी, बला और अतिबला, ये पर्टिकुलरली निकाले हैं तीनों से, जीवनिया, मधुरिया, गणा से, और उसका सिद्ध घृत हम देते हैं, उससे भी पेशेंट को बहुत ही अच्छा रिजल्ट मिलता है, और विल गेट द एडिक्वेट fetal weight for delivery. And this one, and we use the Masanumasic chikitsa, that is called, that is given in Shushruta. That is one Madhuka Shakabijam cha Payasya Suradarucha, that particularly Masanumasic chikitsa, that is mentioned in Shushruta. That is also very beneficial in treating the FGR according to Ayurveda. And Saptadhatu Gami dietary regime. That is, I use that Rasagami Dravya, Raktagami Dravya, Mausagami. Particularly, जो 7 धातु बताए हैं उसे रस, रक्त, मांस, मेद, अस्थि, मज्जा, शुक्र, उससे बढ़ाने वाले जो द्रव्य हैं कि वो समझो एएनसी में यूज किया तो उसके भी बहुत ही अच्छे रिजल्ट मिल सकते हैं. रसगामी मीन्स फॉर एग्जांपल दूध, लाजा, मंड, पेया, रक्त, शिंगाड़ा, खजूर, अंजीर वगैरह. मांस में दूध, दूधी बोफड़ा, लाल या दलिया, श्रीखंड और शिंगाड़ा, खजूर, it's a mausagami द्रव्य. मेदगामी, तूप, लोणी वगैरह, this like paneer, khava, this can use that one also. Astigami, khari, cobra, dink, natsni, that can be used. Majjagami, तूप, लोणी, दूध, बादाम, स्वर्ण सिद्ध जल, नारियल का दूध. Shukragami द्रव्य, दूध, दही, चक्का. You can use as a dietary regime in ANC also. And next slide, please. But I come across it one another study that is very useful in ANC to routine ANC also. That is the meditation, exercise, and diet. That is healthy diet means sattvic diet, and meditation, and one exercise. Next slide, please. Effectiveness. This is the typically different study that project was done by Dr. Shubhda Nil, from Mumbai, and co-investigator, association with the medical wings of Raj Yoga Education and Research Foundation. The project is that the 3-day antenatal care includes the Raj Yoga meditation practice, positive thinking classes, and sattvic food, and practice of soul consciousness. This study is conducted to test the hypothesis that the stress management in pregnancy using 3D ends, three-dimensional ends. That 3 dimension means meditation, diet, and exercise. Whether it would be improve the pregnancy or childbirth outcome. Next slide. The pregnancy is unique state. This state of physiological stress. Stress is unfortunately is a common and ordinary side effect of living. Almost all women experience stress at the some point of the during pregnancy, and this stress can be very harmful during pregnancy, and it the excessive stress can affect the that mother also, fetus also, and after delivery also. That it gives a problem due to the stress, the premature delivery, and FGR, SGA, PIH, abortions, birth defect. The baby gets the autism, dysclasia, hyperactivity, and effects on cognition development, mental health, and last one is the due to the stress is the FOAD, fetal origin of adult disease, the chronic diseases in adult life. That is very important. Next slide. The problem due to the stress in many that when you have already seen the stress management through Raj Yoga, meditation, harmonize the spiritual, mental, physical energy, positive thoughts, emotions, attitudes, and memories. The team, the positive thoughts, emotions, attitude, and memories is very important according to the spirituality. And low fat, high fiber diet, vegetarian diet, antenatal physical and breathing exercise. That project, the result are the 3D care have statistically significant decrease in complications such as preterm deliveries, isolated IUGRs. Definitely isolated IUGR means not due to the fetal infections and that due to the chromosomal abnormalities that you have to exclude it during this study. And PIH associated IUGR are also significantly lower in 3D ANC group. It's because of this, I routinely we are planning this 3D care in our practices also, and we get the definitely good result. Next slide, please. So the last slide is the take-home message. FGR is a concept, SGA is the objective definition. Early diagnosis, close follow-up, timely delivery of the pregnancies of FGR of crucial importance for the perinatal short and long-term outcome. Early FGR should be managed in multidisciplinary tertiary level units. Diagnosis, management of LFGR, especially near term, is complex. The assessment of MCA, PI, and ratio of UPI-PI have a central role in identification of LFGR. Next slide, please. The new emerging things are two. One is evaluate the efficacy of localized injected maternal vascular endothelial growth factor gene therapy is the new emerging thing to improve the fetal growth. Second one, the vasodilator agents and increasing intravascular volume has been suggested to improve the fetal growth and prolong gestation. Using Ayurvedic formulation mentioned in the Ayurvedic classes definitely get the excellent prenatal and postnatal outcome. And last one, the multicentric trial are necessary to formulate the universal use of Ayurvedic drugs. Next slide. Thank you very much. Okay.
Thank you very much, sir, for such a wonderful and informative session. I know this is such a vast topic to discuss, but sir, with his knowledge and experience, concise it very nicely. Thank you so much, sir. Now, I would like to invite Dr. Vishakha to take question answer session. Over to you, Dr. Vishakha.
Thank you, Dr. Ashwini ma'am. Good evening to everyone. Myself, Dr. Vishakha Nagoshe. I would like to thank Dr. Pradeep Musre sir for enlightening the speech and his commendable talk on the subject and clearing our concept. Now I request to the participants, if they have any questions, then raise your hand and put your questions in the chat box. Any questions from the audience? One question is raised from one audience in chat box. What is the role of Odumbar Jal in this condition?
Yeah, definitely. We are using that one also, Udumbar Jal. It's very useful. Many times we'll get the, if oligohydramnios is there, in that case we use that Udumbar Jal. But for FGR cases, not so good for FGR cases. But you can use in oligohydramnios.
Thanks, sir.
Mild
One question
oligohydramnios cases.
More. From which month we can give Tiktak Shir Basti?
Which Shirvasni?
Tiktak
This
Shir
one.
Basti,
Okay.
you mentioned.
We can get that Shirabasti you can give from, because the Shira is the means milk is there. So that can be used in any this one after 7th or 8th months also. You can use that one. Definitely use on you can use them from 8 months onward, because it is not useful in EFGR cases. Definitely after 32 weeks you can use this Kshir Basti in all FGR cases,
Okay, sir.
late onset cases.
Okay, one more question, sir. Please elaborate why Lagumalini Vasanta used in first trimester and Suvarna Malini in second trimester and so on, as you said.
Lagumalini Vasant is a Bruhan, and in that this is a Kalkafri use Mire and लोनी लोनी के उसके भावना दिए हैं उसको, तो इट इज गर्भपोषण उत्तमाहा ऐसा उसका रेफरेंस है। और उसका जो प्रभाव है लघुमालिनी वसंत का, वो रसवाहिन्या रसवग्रंथि रस कार्य रस धात्वग्नि वर्धन है। और जब हम जब देखते हैं कि गर्भपोषण जो बोलते हैं वो उसके उसी संबंध में लघु मालिनी जब फर्स्ट ट्राइमेस्टर में देते हैं तब रस धात्वग्निवर्धन उसका काम प्रभाव अच्छा सा मिलता है, और उससे उसकी वजह से एबॉर्शंस वगैरह रेट भी कम हो जाते हैं। तो मैं लघु मालिनी वसन फर्स्ट ट्राइमेस्टर में यूज करता हूँ। और सेकंड जो है सुवर्णमाली, उसमें स्वर्ण भस्म मौक्तिक वगैरह ऐसा है, और गायीच्या म्हणजे लोण्याच्या भावनात उसमें है ही। तो उसका जो धातु मीन्स रस से शुक्र तक धातु का पोषण उससे होता है, और मोस्टली ओज तेज वर्ण बढ़ाता है वो। तो और स्वर्ण है तो बुद्धि और मन के उसके ऊपर, बुद्धि के ऊपर उसका असर ज्यादा है, इसलिए वो मैं सेकंड में यूज करता हूँ, सेकंड ट्राइमेस्टर। और जो मधुमालिनी वसंत जो है तो उसमें है कि उसमें ये अंडे मीन्स एग्स का जो बलक रहता है उसका भावना दिया हुआ रहता है। तो उसमें जो मीन्स मैनेजमेंट, आयुर्वेदिक मैनेजमेंट में जो बताया है कि आमगर्भ, तो वो उसका रिजल्ट मधुमालिनी का लास्ट मीन्स थर्ड ट्राइमेस्टर में ज्यादा दिखाई देता है, क्योंकि वी यूज द आमगर्भ इन दैट मधुमालिनी वसन।
Okay,
तो
sir.
इसी तरह से
Yes.
ये मैंने डिफरेंशिएशन किया है।
Okay, sir. Next question, sir. Is there any role of Masanomasic Vath in correction of FGR?
मासानुमासिक कॉथ ना?
Yes.
Yes, definitely. I have already mentioned that one also. मासानुमासिक चिकित्सा जो दिए हैं, that one फर्स्ट मंथ से 9th मंथ तक वो यूज किया। समझो जो हाई रिस्क पेशेंट है, जिसमें हिस्ट्री है, सीवियर PIH वगैरह हिस्ट्री है, या इक्लैम्पशिया की हिस्ट्री है, प्रीवियस FGR की हिस्ट्री है, तो ऐसे केसेस में शुरू से ही समझो तुमने चालू किया, फर्स्ट मंथ से ही मासानुमासिक चिकित्सा देना चालू किया, तो उसके एक्सीलेंट रिजल्ट है। और एक मैंने देखा है कि मोस्टली गायनेकोलॉजिस्ट यूज द एस्प्रिन, इकोस्प्रिन 150 milligram for the reduction of PIH and this one. If you use Okshura Siddha Gruta from 12 weeks onward, you no need to give aspirin. Definitely, you can prescribe this Okshura Siddha Gruta from 12 weeks onward till delivery.
Thank you, sir. It's new information for us. Are Brahmaniya, Madhura, and Junior Gandharvas are safe in pregnancy?
हाँ, मैंने क्या किया है उसका कि जीवनीय ब्रोहणीय और मधुरेय गण का जो मैंने बैलेंस करने का कोशिश किया है, तो उसमें शतावरी, अश्वंधा, धमासा, गोक्षुर, विदारी, श्वेत मुसड़ी, बला और आतिबला, ये सब जो कॉमन ड्रग्स है उसमें वो निकाले हैं, और उसका सिद्ध घृत देता हूँ ऐसे FGR केसेस में,
Yes, sir. How
FGR
many?
विथ PIH केसेस में।
Yes, yes. How many times we can repeat Shirabasti?
You have to give at 8 times, 8 days only Shirabasti, 8 days only, and Shirapak we continue till delivery. मीन समझो 7वें महीने में देना है, आफ्टर 32 वीक्स वही देते हैं रूटीनली। तो 32 वीक्स में बाद में हम एवरी मंथ समझो प्रेगनेंसी कंटिन्यू रह गई तो एवरी मंथ 8 days क्षीरबस्ती देते हैं।
Sir, kindly tell us your experience about role of Garbhapal Ras in this condition.
गर्भपाल रस का जो है कि एक तो आई डोंट यूज दैट वन इन फर्स्ट ट्राइमेस्टर, बिकॉज उसमें ना जो घटक द्रव्य है वो सब उष्ण और तीक्ष्ण है, तो इसलिए मैं फर्स्ट ट्राइमेस्टर में गर्भपाल रस नहीं यूज करता. आफ्टर 12 weeks I use that गर्भपाल रस, but I such बोले तो I don't use that गर्भपाल रस routinely. I use this one only, all जीवनीय और ब्रुवणीय गण का जो मैंने बताया अभी, और वही यूज करता हूँ ज्यादा करके, और वसंत कल्प.
If patient had previous history of IUGR, then what precautions should be taken for future pregnancy?
You should start definitely if there is a history of previous maybe having FGR, then you should start monitoring such patient from 12 weeks onward only. From the NTNB scan, you should do the dual marker test, see the PAP-A, and monitor the such patient accordingly. Then after Dopplers, fetal means Dopplers from 26 to 28 weeks, first do the Doppler again, see the uterine PI. Is there any notching and this increased PI? Then you see the umbilical artery Doppler, do the umbilical artery Doppler. Then you have to monitor these such cases according to the Doppler velocity.
So what is
But
the
you have
role
to
of
do surveillance according to that only.
understood, sir. What is the role of sildenafil in FGR and which route should be preferred in FGR?
Many gynecologists uses sildenafil definitely vaginally in IUGR cases, but FIGO state that there is no role in no such a definitive treatment in IUGR of sildenafil.
Okay, thank you, sir. Which company, pharma, Berkshire Siddha Group is better for PIH patient? Which company prefer?
No, I do. I prepare myself only. Definitely, all these groups I do myself. Prepare myself only.
So,
It's very easy. It's a very easy to prepare Gokshur Gruta and all these Gruta in our practice also. And it gets the excellent result also. Don't use manufactured from companies and all.
So one question is raised from Priya Chole ma'am. They said in one of her patient's scan was 5 weeks more than HC at 36 weeks. What does it indicate?
Sorry, I didn't get the point. HCA?
AC was 5 weeks more than HC. So ma'am, please explain.
Abdominal circumference was greater as compared to head circumference. It was 5 weeks more than
5 weeks more than SC.
Yes, sir. Head circumference.
And all the parameters are
normal, sir. Totally normal.
Normal. But
Yes.
AC is greater.
Yes,
Then
AC was
definitely
greater. Only AC was 39 weeks and HC was 34 weeks.
okay, but then we have to see the all the that fluids and all this in is there any congenital
fluid was-
anomaly? Is there any
No,
congenital
sir.
anomaly
Actually-
in fetus?
Sir, anomaly scan was normal. Her AFI was 10 centimeters. She was not polyhydramnios.
Okay.
Fetal weight was 3.3 kg. The only factor was AC is more, actually.
But
So
there
what
is
does
no
it
any.
indicate?
No, I don't. I can't answer of this question because maybe there is a wrong interpretation also, maybe during sonography also. I think so. But we have to see that again. Because AC may be less, but if there is a AC is increased, then there will be the any ascitic fluid and any congenital anomalies, we have to see that.
Right,
Any
sir.
definitely.
Okay, sir. Thank you, sir.
So one question. 36 weeks IUGR, Leica just adequate. Patient not willing to do Doppler. Patient is
Okay.
poor. What precautions and management we do?
Do biophysical profile, and if there is a if BPP normal, then go for also NST also. If you have to manage according to the BPP and NST only. If there is any problem, abnormality in BPP and NST, then go for induction of labor. And already 36 weeks, you go for directly for induction only. Give steroid, and only steroid is necessary. No need of giving Maxwell, because already crossed the 34 weeks. Maxwell should be given before 34 weeks if you want to go for delivery.
Thank you, sir. Any questions from audience? I think all questions are over. Thank you so much, sir. Sir, lastly, it's humble request from our side. If any questions which are remaining, can you take it on WhatsApp group?
Yeah, definitely.
Thank you, sir. It would be definitely enrich and enlighten our knowledge. Thank you.
Yes,
Thank you so much,
definitely.
sir. Now we will proceed with vote of thanks. It's my privilege to deliver a vote of thanks from this webinar on behalf of NIMA-OBGY Society Central and NIMA-OBGY Society Maharashtra body. I would like to express my gratitude to NIMA-OBGY Society Central President Dr. Ashutosh Kulkarni sir, Secretary Dr. U.S. Pandey sir, and Treasurer Dr. Shantulal Sharma sir for their support. I express my gratitude to NIMA-OBGY Society Central President Dr. Kamini Dhiman ma'am, Secretary Dr. Priyanka Nakade ma'am, Treasurer Dr. Vishnu Bhavne sir, and Convener Dr. Rajesh Utane sir for supporting and guiding us to conduct this webinar. I would also like to thank and express my gratitude to our eminent speaker, Dr. Pradeep Musle sir, who took time from his busy schedule and delivered such a wonderful session. Thank you so much, sir. I would further like to express my gratitude to NIMA-OBGY Society Maharashtra President Dr. Suhas Herlekar sir, Secretary Dr. Manoj Gaikwad sir, and Treasurer Dr. Ajay Bal sir for their guidance and support. I would like to thank Dr. Dhaneshri Mahajan ma'am and Dr. Priya Chole ma'am and Dr. Girish Daga sir for their support and technical help. Now, last but not the least, I would like to thank all the delegates for their participation and cooperation for making this webinar successful. Thank you all. Now, with the due permission of all the dignitaries, we are concluding today's webinar. Thank you, sir. Thank you all.
Thank you very much. Yes.